Hello, hello, hello. Okay.
Hi. Hi.
Hi, do the slides move?
Yes. I
Good.
had a question. Were you able
Yeah.
to see the pictures clearly?
Mm-hmm.
Were you able to see the pictures?
Yeah,
Okay.
very much so.
Okay, so you were able to read it and everything?
Mm-hmm. Yep.
Okay. All right, just checking.
Hello, everyone. Diabolically humid out there. Not our favorite type of weather today, that's for sure. But the weekend was sure nice. So I hope you had a chance to get your shorts out and get some vitamin D. Maddie, did you work in your garden? No? Do you have a garden set up yet at your new house? Oh, okay. So next season. Hey, Michigan Bulb has a deal on bulbs if you are into bulbs. Right, you can get late, middle, and early bulbs if you know, tulips and then the later one. So I'm trying at my house to get stuff that goes early, middle, and late. I haven't been quite successful yet. The late stuff keeps dying. When I had a dog, I had an excuse. As the dog would dig it up and overwater it. And yeah, now I have no excuses just because I stink at trying to plant things. We are talking about polycystic kidney disease. If you need to make up quizzes, Mrs. Schaefer's back. So please go see Mrs. Schaefer. And if you don't have things that I haven't handed back yet, I'm going to start storing them in the office because it's just getting, it's too much for me to keep handling things and bringing them down and trying to hand them out and people aren't here and so on and so forth. So I'm going to start storing them in the office. So if you want to pick up assignments, go see Mrs. Schaefer. So makeups and for picking up assignments, see Mrs. Schaefer in the office. She's back and doing much better. I feel like we should start with a word of prayer today. Lord, thank you for nice weather, and thank you that our end of this semester is in sight. We pray you'd help us use the time wisely, and please help us not to lose heart, but help us run the race firmly all the way to the end. In Jesus' name, amen. All right, so with polycystic kidney disease, you have a protein called polycystin. There's two of them, polycystin 1 and 2. They're components of the so-called primary cilium of the tubule cells. The primary cilium keeps growth of those cells in check. If the primary cilium is defective, these cells will grow uncontrollably. They will make lots of these fluid-filled cysts inside the kidney, and the kidney will stop working. So the biggest thing you start to see is that the blood pressure will start to creep up even very early in life. You'll start to get some flank pain. You'll be at higher risk also for kidney stones and things like that. And renal insufficiency will start to develop. The big indicator of renal insufficiency is decreased urine output. You'll also start to see electrolyte imbalances. And what is the cytokine made by the kidneys that guarantees you have enough red blood cells? Anybody remember? Erythropoietin. Since erythropoietin production will also be affected, anemia may also be a factor in these patients as well. So the timeline of the disease, how bad it is from patient to patient, that's pretty variable from person to person, albeit those with mutations in the polycystic kidney disease 1 gene will tend to have larger kidneys with more cysts, they'll have more severe disease than those who have mutations in polycystic kidney disease gene 2. So polycystin 1, defects in polycystin 1 are worse, create worse disease than mutations in the polycystic 2 encoding gene. So again, the more severe, the earlier you will have the onset of symptoms. So 50 to 75% or so of patients that present with hypertension will actually have normal renal function. So some sort of early onset hypertension is usually the tip-off. There are other things that can cause early onset hypertension, but this should get your spidey sense tingling. Long-standing hypertension can result, of course, in damage to the Balance capsule glomerular border, kidney failure, aneurysms, particularly in the circle of Willis in the brain, so-called Barrett aneurysms. Those can be very dangerous. Cardiac valve disease, complications during pregnancy, both for the mother and the baby, and so on and so forth. There are lots of spin-off consequences to this condition. So those who have the autosomal dominant polycystic kidney disease, that's what the ADPKD stands for. They're going to be subject to increased numbers of kidney stones. Those stones will tend to consist of uric acid because uric acid excretion is going to be on the rocks, so to speak, mixed sometimes with calcium oxalate. Calcium oxalate forms the majority of kidney stones. Some, high 80% of your kidney stones are calcium oxalate. Urate stones are a bird of a different feather, whereas oxalate stones will tend to be kind of circular. Urate stones, if you've ever seen a uric acid crystal, are going to be little needles. And those little needles will do a lot of damage. So this decreased excretion of ammonia and the acidic pH and decreased citrate concentrations, they're going to contribute to the formation of those stones. So by the time they're 60 years old, half of patients will present with end-stage renal disease. The only way they're going to be able to deal with metabolic waste will be dialysis or kidney transplants. If you do a biopsy, you'll see sclerosis of the vessels, inflammation, fibrosis. The damaged tissue will get replaced with scar tissue. That'll cause further obstruction, and you'll just have death of the tubular cells in general. One of the ways you can accelerate this is if you overuse nephrotoxic medications. One of those nephrotoxic medications you should be thinking of are non-steroidal anti-inflammatory drugs. So things like ibuprofen, aspirin, not so much Tylenol, naproxen sodium, things like that. Those can be very hard on the kidney. So can aminoglycoside antibiotics, things like that. All of those can team up essentially on a kidney that's already teetering. Also, poor dietary habits, taking in excess amounts of salt, not drinking enough. All of these also can gang up on a kidney that's not working so well. And then diabetes and hypertension are also not so great for your kidney as well. Because of the damage to the kidney and the degeneration in the kidney, that puts you at increased risk for cancer of the kidney, renal cell carcinoma. When it does present, it will present atypically. Usually one of the signs of this is flank pain, but these patients already have flank pain. So it can be difficult to detect renal cell carcinoma early enough to be able to treat it effectively. Renal cell carcinoma is typically much more aggressive in people with the autosomal dominant polycystic kidney disease. The enlarged kidney can actually start to compress the intestines, and if it gets big enough, it can even start to impinge on the inferior vena cava. People with the autosomal dominant polycystic kidney disease can also present with polycystic liver disease. Primary cilia also play a role in controlling cell division in the liver. Now, the liver is a much more regenerative organ than is the kidney. You can donate 90% of your liver, and that 10% of your liver will actually grow back. So this is a tissue that has an incredible amount of regenerative capacity. Without polycystin, people with the autosomal dominant polycystic kidney disease can also present with polycystic liver disease as well. They'll tend to have the kidney manifestations much earlier in life. This usually increases the risk of it, the frequency of it increases with patient age, of course. So usually that won't be the primary finding, it'll be the secondary finding. Pancreatic cysts can also occur. That's not very common, but they do occur. And if they do occur, they tend to be small, and they don't usually tend to interfere with pancreatic function. It's rather rare if they do. Seminal vesicles. What are seminal vesicles? Who remembers what seminal vesicles are? Yeah, where? Are they in their head, in their feet? Where? Okay, those are so-called accessory sex organs. Accessory sex organs. And they secrete materials for this thing we call semen. There's three of them. Seminal vesicles is one of them. Can you remember the other three? Other two, excuse me. Sorry? No, the vas deferens is the tubule system that brings the spermatozoa into the urethra. There are way stations along there where they get those secretions. Remember what the glands are called? Seminal vesicles is one of them. What's the other two? Sorry? No, the ductus deferens is the more distal part of the vas deferens. It's got the shape of a walnut. It gets larger in older men. Prostate, thank you, that's two. What's the third one? Farmer John had a cow. Cowper's gland, thank you. Cowper's gland, Cowper's gland. Seminal vesicle, prostate, and Cowper's gland. So you get cysts also in the seminal vesicles, but that doesn't seem to do much either. Most life-threatening manifestation are aneurysms. Intracranial aneurysms, that's usually the result of uncontrolled hypertension. That occurs in 10 to 20% of folks. Highest rates are in those who have increased positive family histories of intracranial hemorrhage. You also see increased amounts of intracranial hemorrhage, intracranial aneurysms in people who are on warfarin as well, the anticoagulant warfarin. Mitral valve prolapse is seen not often, but a quarter time. So that is something that will need to be screened for as well. Now, here's the part about this that's a little weird. Turns out that the mutation, the disease is inherited, has a dominant, but you don't get the disease until you have two copies of the mutation. Let me explain. So if you inherit one copy of the mutation, as your kidney develops, as those cells divide, one of those cells usually will experience a mutation in the other homolog. Then those cells will have a growth advantage over the other cells, and they'll take over the kidney and form the cysts. That's why you get the variability in the disease. So from a cell biological perspective, the disease is a recessive, an autosomal recessive. From an inheritance perspective, it looks like a dominant, because most people who inherit the one mutation on the one copy of the chromosome will tend to have the disease. But how severe the disease is depends upon how early in kidney development that other mutation arises. Does that make sense? Blank stares tell me no. So increased cell division increases your risk of mutations, right? That's why tissues that get damaged, regenerate, damage, regenerate, damage, regenerate. They're at higher risk for tumors. So things that damage and regenerate, ovaries, endometria, mammary glands, prostates, things like that. Those are all high risk for tumors. When the kidney develops, it goes through lots of rounds of cell division. And if you have a mutation in polycystin 1 encoding gene or polycystin 2 encoding gene, that increased number of cell divisions increases the chances of having a second mutation occur in the other copy of it. And then those cells will be homozygous for the mutation. They'll go on and form the fluid-filled cysts. If this occurs early during kidney development, this disease will be very severe. If it occurs later during kidney development, then the disease won't be that severe. Is there a chance it won't occur at all? Yeah, there is. That's why this disease shows genetic heterogeneity. Genetic heterogeneity. So the polycystins are found in the primary cilia of renal tubules. They're also found in cardiac myocytes. They're found in the cells that will help form heart valves and vessels as well. That's why you have multi-organ involvement, but the biggest involvement is with the kidney. Mutations in the polycystin 1 encoding gene causes more severe disease with younger presentation of symptoms, increased severity of renal disease, and faster progression to end-stage renal disease. The manifestation in other organ systems varies, and it varies pretty wildly. Again, because on the cell biology side of things, the disease is a recessive. But inheritance-wise, it acts like a dominant. And one copy will determine if you have the disease, essentially. So these are some diagnostic traits, essentially, that will predictably determine the severity of the polycystic kidney disease. So hypertension before the age of 35. If hypertension before the age of 35, your disease will be predictably more severe. If you have hematuria before the age of 30, that's a good predictor that your disease will be more severe. You have hyperlipidemia at any age. Pretty good indicator that your disease is going to be more severe. And if you have with polycystic kidney disease, sickle cell disease of any type, your disease will be more severe. Now, polycystic kidney disease is subject to what's called genetic modification by the genetic background. Let me illustrate what I mean by genetic background. Let's say you go to the symphony. And let's say they're playing Beethoven's Ninth. And Beethoven's Ninth is 4 movements. The last movement's with the choir. It is a rousing piece. And the second movement is this very fast. Some of you may be familiar with this. Sound familiar? It's really famous. Okay, Haley's heard it. Some of you have heard it. What if in the middle of that piece, the oboes suddenly broke out in a jazz solo? You probably the audience probably look at each other and say, does this person have the right music? This person have the right place? Now, it might be a really cool solo, but it's in the wrong place at the wrong time. You're there to hear the second movement of Beethoven's Ninth, and instead you're hearing some sort of big band jazz solo. It's wrong. It doesn't fit. Hopefully, somebody would pick that musician up and take them outside and say, okay, just put your hat down and play there for pennies or something. You don't belong to Beethoven's Ninth. But what if you were at a jazz concert and you heard the same solo? You'd say, that's a really cool solo. Background. Background determines whether or not a certain something fits. Genetic background determines if certain genes fit with a certain background, because genes don't exist in isolation. They're interacting with lots of other genes in the genome. Okay, you think you understand genetic background? Polycystic kidney disease, its severity can be modified by other genes. They're called genetic modifiers. And it's this concept of genetic background. Certain alleles of certain genes can make the disease a lot worse. Others alleles can make the disease not nearly as severe. That's why you can have the same allele in 2 different family lineages. One family will have the disease really badly, the other will not. And that's due to genetic modification. Genetic modification. So homozygosity or mutations in these genes will cause something called renal agenesis. Renal agenesis. If the baby is born without kidneys, then it can't regulate amniotic fluid, because once the baby's face and pharynx develops, the baby starts to swallow the amniotic fluid, and then the swallowing and urinating helps recycle the amniotic fluid. And without kidneys, you suffer from a condition called oligohydramnios, meaning not enough amniotic fluid. Oligohydramnios is rather deleterious to the baby, and the baby will abort spontaneously, typically during the second trimester, usually about the early middle of the second trimester. Polycystic kidney disease, the polycystin genes, are subject to expansion of a triplet repeat. So this is another triplet repeat disease. And so by sequencing the gene, you can discover if someone is at risk for further expansion and having the disease essentially arise in future generations. All right, so the renal cysts can be seen by renal imaging. If someone does not yet have any symptoms, you can see those cysts very nicely. With proper renal imaging, you can see them with an MRI or a CAT scan. If someone has these round fluid-filled renal cysts, then they should undergo genetic testing. If they undergo genetic testing, they will be tested via a panel that will test for both mutations in polycystin 1 and 2. If you have a patient who doesn't have a family history, you might want to have siblings tested as well, or parents tested. And if there is a family history of polycystic kidney disease, then the following will usually indicate the presence of the disease: enlarged kidneys or liver, mitral valve prolapse, abdominal hernia, or unexplained hypertension in a young healthy person. So siblings will have a 1 in 2 chance of being affected. And if that's the case, then testing also will tell them who is a candidate to be a kidney donor, because the person will almost certainly need a donated kidney. And genetic counseling is recommended essentially for those with a positive family history of polycystic kidney disease. So to manage people with this disease, it's clear that your ACE inhibitors, your angiotensin converting enzyme inhibitors, and the ARBs, sartans, the angiotensin 2 receptor blockers, are renal protective, and they increase blood flow through the kidneys. They can reduce the formation of arterial plaques. They also reduce the damage to the kidney. You want to avoid excessive dietary protein consumption. That can put a lot of strain on kidneys that are compromised. Also, certain dietary supplements, for example, creatine, can be very hard on some of these kidneys like these, and they should steer clear of those types of supplements. Likewise, these patients should steer clear of caffeine or other types of sympathomimetics. So pseudoephedrine or things like that. That will help preserve kidney function, minimize damage. If the cysts become a big problem, they can be surgically removed. If the cysts become infected, you'll have to go with the big gun antibiotics up to IV. Treating any sort of pyelonephritis is difficult. You'll need IV antibiotics at that stage. Aneurysms in the brain, you have to use an MRI screen for those. And then if someone has a positive history, or if they have the signs, they need to monitor blood pressure. They should get a home blood pressure monitor, keep a log essentially. Now you can do that on your phone, which is really makes it really easy. That can even report straight to the doctor's office if you set it up a certain way. Evaluate renal function and structure on a regular basis. Evaluate lipid structure on a regular basis. Evaluate blood lipid screen for heart valve and aortic disorder using imaging. Provide patients with lists of nephrotoxic drugs, not just prescription ones, but also over-the-counter ones as well. And avoid caffeine. It contributes to cyst growth. There was a report that there was a safe level of caffeine for these patients that was unchallenged in the subsequent publication. So the thinking is now there really is not a safe level of caffeine for these people. So caffeinated teas, coffee, chocolate, they should have to forswear white chocolate would be fine, but avoid caffeine. And then liver involvement too, give them a list of hepatotoxic agents, not just prescription, but also over-the-counter agents. And encourage them, if there's a question, just have them contact the physician and ask. People with polycystic kidney disease really should not smoke. Smoking damages the kidneys, smoking damages the liver, smoking increases the risk of renal cell carcinoma. They're already at increased risk for renal cell carcinoma. They should not smoke. Also, they should remove themselves from exposure to secondhand smoke as much as possible. I realize the effects of secondhand smoke are up to debate, but I think it's worth it to tell the patient just hedge their bets. They should reduce their alcohol intake as well. Light drinking occasionally is probably fine. Moderate drinking is not fine. There aren't any FDA-approved meds for polycystic kidney disease except for your ACE inhibitors and angiotensin II receptor antagonists. The so-called VACTAMs, vasopressin 2 receptor antagonists, have been studied. Somatostatin analogs that are normally used to treat acromegaly, those have been studied. The jury's out on these. The clinical trials, the results on the clinical trials were pretty underwhelming, frankly. Now, there are other conditions that cause renal cysts. There's a list of them here. I won't go through these, but keep in mind, just because you see renal cysts doesn't mean they automatically have polycystic kidney disease. There are other conditions that can cause cysts in the kidneys. Tuberous sclerosis causes hamartomas. Those are soft tissue, mesenchymal tumors, really all over the body. Kidneys is one place where they can occur. If they have hamartomas in the kidney, they'll usually have them other places too, with tuberous sclerosis. Von Hippel-Lindau syndrome, that is a condition, again, where you get tumors all over the body. OFDS type 1, glomerulocystic kidney disease, Hashimoto's syndrome, these are all conditions that can cause renal cysts. Genetic testing is necessary to exclude these. There is an autosomal recessive version of polycystic kidney disease. These cysts tend to be bilateral. Their microscopic appearance at biopsy is very different than what you see for autosomal dominant. The parents of these people will not be affected. And so these features can nicely separate the autosomal recessive polycystic kidney disease from the autosomal dominant. So, to summarize, autosomal dominant polycystic kidney disease is a multisystem disorder. It affects the kidneys first, but can affect other organs like the liver, the aorta, other organs as well. They're inherited in a dominant fashion, albeit on a cell biology level, they're recessive. They're due to defects in the polycystin proteins. With the bad kidneys comes hypertension, flank pain, renal insufficiency. To confirm this, you need genetic testing. There's no cure, but there are lifestyle modifications and medications that can diminish the demise of the kidneys. Any questions about polycystic kidney disease? This is common enough so that you'll probably see this in your practice. And now for something completely different. Rheumatoid diseases consist essentially of the immune system attacking itself, attacking essentially your own tissues. And one of those tissues can be, of course, the joints. So chapter 21 is all about rheumatoid diseases, diseases that you've probably heard about. So the first of these is rheumatoid arthritis. Do any of you know anyone with rheumatoid arthritis? Most of you. I'll bet you, donuts to dollars, if you take a family history of those people you know, it's going to run in their family. I'll bet you, bet you, bet you. This condition tends to run in families. So if you do a twin study, where you look at identical twins from families that have rheumatoid arthritis, identical twins have noticeably, measurably higher rates of rheumatoid arthritis than fraternal twins. Interpret that result for me. I'm sorry?
Yes, again.
Identical twins. You take twins from families that have rheumatoid arthritis in them. You look at identical twins in those families, then look at fraternal twins. And so identical twins are genetically very similar, virtually identical. Not completely identical, turns out, but virtually identical. Fraternal twins are genetically not identical. The identical twins in those families will have measurably higher rates of rheumatoid arthritis than the fraternal twins. Every time. Every time. Interpret that result for me.
It's very highly like genetic.
Genetics is a big determining factor in whether or not someone will develop rheumatoid arthritis. Exactly. Exactly. Well done, Haley. Exactly. So when you look at alleles of these HLA proteins, these are human leukocyte antigens. These human leukocyte antigens, they are encoded by the major histocompatibility complex. This complex encodes those barcodes on the surfaces of your cells. Remember, there's class 1 and class 2. Major histocompatibility antigens, major histocompatibility genes. The class 1s are expressed on the surface of every nucleated cell. The class 2s are expressed on antigen-presenting cells. So certain alleles of this particular one, HLA-DR, that's one of the class 2s. There are alleles of DR, namely DR1 and DR4, and then also alleles of HLA-DQ, another class 2 major histocompatibility complex gene. Certain alleles are strongly associated with rheumatoid arthritis. We would take 100 people with rheumatoid arthritis. We would ask what alleles do they have at these loci. 80 times out of 100, 90 times out of 100, they have one of these alleles. But it is clear that when people develop rheumatoid arthritis, there is a trigger. There is a trigger. And again, these people, you guys have indicated you know, with rheumatoid arthritis, I will bet you dollars to donuts. If you ask them the story of when they had their first rheumatoid arthritis attack, there'll be some sort of accident, sickness, illness, event in their life that kicked it off. Rheumatoid arthritis has some sort of trigger. Can be specific pathogens, can be cigarette smoke, can be an illness they had, can be an accident they had, can be an injury of some sort. That trigger will be different for each person, but there usually is some sort of trigger that kicks it off. So there is a distinct genetic basis to rheumatoid arthritis, but there are other factors involved in whether or not someone will develop rheumatoid arthritis. So genetics is an important influencer, but it's not the only thing. We're going to see it's the same case with the other disease we'll look at, systemic lupus erythematosus. Strong genetic determination, but other factors are at play as well. Pause here. Any questions? No? Moving on. So rheumatoid. Rheumatoid comes from rheumatism. Rheumatism. This broadly refers to musculoskeletal diseases. Rheumatoid arthritis is a chronic inflammatory disorder that mostly affects the joints. Doesn't exclusively affect the joints, but it mostly affects the joints. It can, however, involve other systems like the skin and the lungs. So at a healthy joint where two bones meet, what do you have on those joints? What kind of cartilage? 3 types of cartilage. Let's rehearse. Sorry? Fibrocartilage, right? Fibrocartilage. Where's that found? Some joints. The pubic symphysis, where your pelvic bones come together, there's a disc of cartilage there. That's fibrocartilage. The other one is elastic cartilage. Where's that found? Trachea. Your trachea, your larynx, things that need to be a bit more stretchy. And then the other one, the clear one, that was a hint. Hyaline cartilage. That's the one that's found at articular surfaces, hyaline cartilage. And then this cartilage is lubricated by a fluid. What's that fluid called? Synovial fluid. Very good, synovial fluid. Someone else said it too. Someone over there said it. All right, now if you have a synovial joint, let's take the knee, for example. You have two bones. You also have surrounding it a fibrous capsule that is continuous with the periosteum of the bone. And this fibrous capsule is lined with a so-called synovial membrane. And it has cells that produce synovial fluid and remove debris. So pretty important cells. The synovial fluid is a viscous fluid. It's jelly-like, it lubricates the joint, it contains hyaluronic acid. You can get that shot into joints if you get an injured joint, and that can help lubricate the joint. That's made essentially from chicken cartilage. The chicken cartilage and human cartilage are very similar. And together, the synovial membrane and the articular cartilage form the inner lining of that joint space. The articular cartilage forming the lining of the bone, the synovial membrane forming the inner lining of the fibrous joint capsule. So rheumatoid arthritis is an autoimmune process that's triggered by some sort of interaction between genes and the environment. So we talked about essentially the particular genetics of someone. Genetic factors can cause modification of our own antigens such that antibodies are made against them. So for example, there are two proteins in the joint. There's type 2 collagen. Type 2 collagen, by the way, is a cartilage-specific collagen. Then there's another protein called vimentin. And these proteins get modified by a process called citrullination. Citrullination that you can see up at the slide. So this enzyme, arginine deaminase, takes arginine and it takes this amino group here, sticks some water on there, and you convert arginine to citrulline. Citrulline, that's called citrullination. And citrullination, this is strongly induced by inalveolar macrophages, by cigarette smoke, by certain diseases, by certain types of stresses to the knee, or things like that. And now this occurs, and your immune system looks at that and says, that's not normal. And it mounts an immune response against it. And if you look at rheumatoid arthritis patients, they have an increased tendency for their immune system to respond to citrulinated proteins. This has been well studied in a variety of different model systems. You take serum from RA patients, you give it citrulinated protein. Their serum contains a lot of antibodies against citrulinated proteins. And if you ask, do the white cells attack citrulinated proteins? They do. They attack them robustly. Whereas people without rheumatoid arthritis don't respond to citrulinated proteins nearly as robustly. So it looks like this is something that kind of happens in your joints just every day, and it gets replaced, your body deals with it, and your immune system just says, whatever. Whereas in RA, your immune system are kind of a bunch of Karens, if you will. And these Karens say, no, 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 you can't do that. And it responds to them, and you get an immune response against those proteins. All right, with me? Yes? So these antigens will get picked up by antigen presenting cells. They get carried to lymph nodes. They will activate T helper cells. The T helper cells then stimulate B cells. What do B cells make? The B cells in your body make thank you, B cells make antibodies. They differentiate into plasma cells and they make so-called autoantibodies. Autoantibodies. And then the T helper cells and antibodies enter the circulation, they reach the joints, and there they will secrete pro-inflammatory cytokines. Those pro-inflammatory cytokines, these are important because these will be necessary to talk about when we get to treatment of this. They will secrete things like interferon gamma. They will secrete interleukin 17, and they will secrete tumor necrosis factor alpha. All these essentially rev up the immune system so that now the whole immune system becomes a bunch of Karens, so to speak. They also make interleukin 1, interleukin 6. These will stimulate those synovial membrane cells to proliferate. They will proliferate and they will form a little thick spot called a pannus. A pannus. Pannus is Latin for apron. It's the same word from which French panier. Anyone have French in high school? Panier? Panier means basket in French. Pannus, panier, they're same root. This pannus is made of synovial membrane, but it also contains scar tissue that contains fibroblasts, inflammatory cells, and the pannus will grow into the articular cartilage and damage it. And it will also erode the bone, because the synovial cells will start to make proteases that break down the proteins in the articular cartilage. And without protective cartilage, the underlying bones are exposed and they rub. What happens when bone rubs against bone? Right, it grinds. It's not a pretty sight. So one of the things you can detect in the blood of people with rheumatoid arthritis are antibodies to citrullinated protein antigens, or ACPAs, ACPAs. The other thing you find are antibodies that target the FC domain of IgG antibodies, and these are called rheumatoid factors. Now, rheumatoid factor is also found in a few other diseases, but if you find antibodies to citrullinated protein antigens and rheumatoid factor, it's a pretty safe credit to Navy beans. You've got rheumatoid arthritis, particularly if there's a family history for it. You'll also see antibodies to other modified proteins. This is non-enzymatic. amino acid lysine will react with urea and cyanate that's generated by myeloperoxidase from neutrophils, and it will generate this amino acid, almost citrulline. You'll get antibodies essentially to carbonylated proteins. You can detect those in the blood as well. And this is rheumatoid factor, these IgMs that bind other IgG antibodies, rheumatoid factor. And one of the main targets will be type 2 collagen, which is specific to cartilage and vimentin. These antibodies bind to their targets. They form immune complexes that activates the complement system. You damage a tissue, and then you start to make new blood vessels. Do blood vessels help joints work very well when you get blood vessels made right in the middle of the joint? No, the blood vessels are just going to get damaged. And so now the joint's going to bleed inside the capsule. What happens to blood when it's not inside vessels? Irritates other tissues, doesn't it? All right, so this little picture here essentially shows you the development of the penis. I should have forwarded that. So normally this capsule should be relatively thin like this. Now it's growing into the joint. That's the penis. See the damage it's doing to the articular cartilage? This penis can usually be seen pretty easily on imaging. Here is an example. You probably can't see that. Is that better? So this is an H&E stained penis. This is from a hand, essentially. You can see essentially the penis tissue. Here, can you see how different that looks from this? That looks like cartilage. Does that look like cartilage? No. That's penis tissue that's growing into the cartilage. See it here? It's growing into the bone too. It's eroding the bone. It's your own synovial membrane worming its way across your bone, eating it as it goes. Sounds horrible, doesn't it? It is. It is. All right, so the T cells will activate osteoclasts by making this molecule that activates osteoclast rancle. That'll further degrade the bone. The penis destroys the cartilage. You get complement cascade that further degrades the tissue. Then you get angiogenesis, essentially. Now, these cytokines don't just stay in the joint space. If you get extra organ involvement in rheumatoid arthritis due to circulation of those pro-inflammatory cytokines, and this will cause the extra-articular manifestations of rheumatoid arthritis. So let's talk about some of those extra organ manifestations. So in the lung interstitium, fibroblasts can be activated by the circulating cytokines. They will proliferate and they will produce scar tissue. That scar tissue makes it harder for alveolar gas exchange to occur. The pleural cavities that surround the lungs will also get inflamed. They will therefore fill up with fluid. That's called a pleural effusion. Pleural effusion. This will prevent proper lung expansion. you can see it. Now, you can see it there pretty nicely. You can see the inflamed tissue over there. Should a pleural membrane be that thick? No, that's inflamed, or it's scarred, or both. So interleukin 1 or interleukin 6 activates protein breakdown in skeletal muscle, also in the skin. You'll get these kind of round-shaped connections of macrophages and lymphocytes around areas of necrosis. These are called rheumatoid nodules. Rheumatoid nodules. In response to cytokines, the liver will start producing high amounts of hepcidin. That's an iron storage protein. It's a regulator of iron storage, rather. This protein will decrease serum iron levels by inhibiting the absorption of iron from the gut and trapping it in macrophages or liver cells, thereby affecting proper iron storage. And then it can also affect the other joints as well, which we'll look at in just a bit. You can also get inflammation of the sclera of the eyes, and so-called Felty syndrome is this rare autoimmune disease characterized by rheumatoid arthritis, enlargement of the liver, and neutropenia, essentially. And here's essentially what happens to the joints of the extremities. These will usually affect multiple joints, usually 5 or more. Usually it'll affect them symmetrically. So it'll affect the same joint groups on both sides of the body. The joints most commonly affected include the metacarpophalangeal and then proximal interphalangeal joints, and then the metatarsophalangeal joints of the feet, which you can see here. No, you can't because it's blurry. See the spurs? You see the damage on the spurring? And then, need I say more essentially about that? That pretty much tells me the story. That's all we have time for today. We'll finish this and get into neurofibromatosis.
Thank you.
Very welcome. Have a good day.
You too.